New hypertension guidelines. Recently, the American College of Cardiology and American Heart Association released major changes to the guidelines for the detection and management of hypertension. Over the last few years, there's been mounting evidence that lowering the threshold for acceptable blood pressure has a significant effect. But you or a patient may ask, hypertension doesn't hurt, so why care? Chiropractors are accustomed to dealing with pain, and patients generally don't seek care for something that doesn't hurt. However, most life-threatening conditions in the early stages are almost always asymptomatic. Chiropractors, as portal of entry practitioners, are well positioned to screen for a number of these conditions, including diabetes, skin cancer, and hypertension, among others. The assumption that patients are regularly screened by their MD or that hypertensives are compliant with recommendations is often not true. And remember that hypertension can lead to hypertensive heart disease, aortic dissection, multi-infarct dementia, retinal damage, renal failure, and it's the leading cause of hemorrhagic stroke. In fact, 50% die of ischemic heart disease and 33% die of stroke. And according to reports published in 2010, high blood pressure is in fact the leading cause of death and disability-adjusted life years in the world. The new updated 2013 guidelines were published in two journals, Hypertension and the Journal of the American College of Cardiology. This 283-page document is entitled 2017 Guideline for the Prevention, Detection, Evaluation, and Management of High Blood Pressure in Adults. So what's new? Lots. Most notably, there are changes in the categories of hypertension, including lowering the blood pressure threshold for hypertension and the elimination of prehypertension as a category. Recommendations are now not just based on hypertension level, but also on an individual's atherosclerotic cardiovascular disease risk estimate. This risk estimate is accessible online and takes into consideration factors such as age, gender, systolic blood pressure, lipoprotein profile, and associated risks such as diabetes and smoking. We'll look at these in a moment. In the new guidelines, there is more emphasis on home monitoring and ambulatory monitoring, in particular for differentiating the white coat effect and revealing masked, uncontrolled hypertension. As we will see, with the lowering of categories, there is more focus on lifestyle modification as a preventive and co-management approach. With medications, there are some changes in drug management recommendations, including a more aggressive approach to stage 2 hypertension. So why these changes now? Among others, in a study entitled A Randomized Trial of Intensive versus Standard Blood Pressure, the SPRINT Research Group, published in the New England Journal of Medicine in 2015, the researchers concluded that, quote, participants assigned to an intensive systolic blood pressure treatment target of less than 120 versus the standard systolic blood pressure treatment goal of less than 140 had a 25% lower relative risk of major cardiovascular events and death and a 27% lower relative risk of death from any cause, unquote. With these new designations, 30 million more Americans have hypertension. Now, 46% of U.S. adults have high blood pressure versus 32% under the old guidelines. Rates will nearly triple for men under 45 to 30% and double in women at the same age to 19%. Using the new guideline terminology, with the updated guideline, most black adults have hypertension, 56% of women and 59% of men, so that black men now have the highest rate of hypertension. For people over 65, the guidelines eliminate a recent adjustment allowed 3 years ago to raise the systolic threshold to 150. Now the guidelines state that everyone over 65 should be treated if the systolic reading is 130 unless they're too frail. It's important to note that although an additional 14% of U.S. adults have hypertension under the new guidelines, only 2% of these additional individuals need initial medication. Recommendations are that the rest should try healthier lifestyle changes. Poor diet, lack of exercise, and other bad habits cause 90% of high blood pressure. We can see the elimination of the category of prehypertension and the lowering of normal blood pressure systolically so that the normal is not 120 but less than 120 and diastolically less than 80. A systolic blood pressure of 120 to 129 is now considered elevated even if the diastolic blood pressure is below 80. Also note that hypertension is lowered by 10 points to 130 to 139 systolically or 80 to 89 diastolically. And now what was stage 1 hypertension is now stage 2 hypertension at 140 or greater systolically and 90 or higher diastolically. It's important to take an accurate reading and avoid in particular false transient high readings. Patients should not smoke, drink caffeine, or exercise 30 minutes prior to having their blood pressure taken. And here we can see other features that may transiently raise a patient's blood pressure. Next, we can see the patient positioning factors that influence blood pressure readings and by how much. They should be sitting with their feet on the floor, not with crossed legs, and with the arms supported at the heart level. They should have their back supported and sit up straight. Preferably, the patient relaxes for 5 minutes prior to having their blood pressure taken. And remember, do not apply the SFIG over the clothing. And the most significant factor is the size of the cuff. Here we can see the recommended cuff based on the circumference of the arm. The intention is to have the bladder of the SFIG cover 4/5 or 80% of the arm circumference. False readings can be as high as 50 millimeters systolically. So this is a very important factor, in particular for large patients who might be assumed to have high blood pressure when in fact the cuff was simply too small. Given it's been shown that ambulatory blood pressure monitoring provides a better method to predict long-term cardiovascular disease outcomes than office blood pressure measurement, it should be considered the reference standard. These portable monitors are usually set to read blood pressure every 15 to 30 minutes during the day and every 15 minutes to an hour at night for a 24-hour period. This may be uncomfortable for the patient, which may affect proper measurement. But while ambulatory blood pressure monitoring is the best out-of-office measurement, home monitoring is often more practical. It's important to follow specific procedures to guarantee accuracy. Patients should take at least 2 readings 1 minute apart each morning before medication and each evening before supper, and they should obtain weekly readings 2 weeks after a treatment change and the week before a clinic visit. Let's discuss the white coat effect. What if a patient's reading is high, but they insist it isn't usually? We'll recheck over a couple of days, and then if the systolic blood pressure in office is between 130 to 159 and diastolic is between 80 to 99 after a 3-month trial of lifestyle changes, screen using daytime ambulatory or home blood pressure monitoring. If it's less than 130 over 80, the white coat effect is likely. Monitor annually. If it's above 130 over 80, then lifestyle modification plus medication is recommended in the new guidelines. Now the opposite phenomenon, masked uncontrolled hypertension. If a patient has multiple risk factors for cardiovascular disease or demonstrates end organ damage, but not hypertension on clinical exam, screen for masked uncontrolled hypertension using home monitoring. If home monitoring indicates hypertension, confirm with ambulatory blood pressure monitoring. If that is elevated, refer for further evaluation and possible medical management. Although the vast majority of hypertension is idiopathic, called essential hypertension, we must look for indicators of a secondary cause of hypertension. These include drug-resistant hypertension, an abrupt onset of hypertension, which in seniors is often renal artery stenosis, onset before the age of 30, exacerbation of previously controlled hypertension, onset of diastolic hypertension in older adults, and unprovoked or excessive hypokalemia. It's also important to look at the higher risk patients who have a strong association with hypertension. Here we see the top 3 disorders that account for hypertensive patients: renal artery stenosis, primary aldosteronism, and obstructive sleep apnea. These ranges generally indicate those with just hypertension on the low end or those with uncontrolled hypertension on the high end. And given the rise of atrial fibrillation due to its association with obesity, it's important to know that hypertension is a risk factor for atrial fibrillation and that hypertension is present in more than 80% of patients with atrial fibrillation, by far the most common comorbid condition, regardless of age. So now let's move on to the new management approaches that include the atherosclerotic cardiovascular disease 10-year risk estimate coupled with blood pressure levels. Simply Google for this online calculator and enter the information requested. The tool has the advantage of storing and comparing readings. So here it is. We've entered in the following: a white male patient, age 59, with a systolic blood pressure of 130, cholesterol of 200, low-density lipoproteins of 130, and high-density lipoproteins of 60. He's a non-smoker, non-diabetic, and not taking either statins or aspirin. We see that his 10-year risk is 7.1%. Now, let's change that profile. This is now a 45-year-old African-American female with the same risk factors as the white older male, just to see the influence of race and age. We see the risk drops to only 1%. So let's see how this factors into management. Using the new guidelines, those with elevated blood pressure should be given lifestyle modification advice and rechecked in 3 months. For stage 1 hypertension with an ASCVD 10-year risk estimate less than 10% or without clinical cardiovascular disease, lifestyle modification is recommended for 3 months and then reevaluation. Guidelines now recommend 1 blood pressure lowering medication for those with stage 1 hypertension with clinical cardiovascular disease, diabetes or chronic kidney disease, or a 10-year ASCVD risk of 10% or greater. For stage 2, the recommendation is 2 blood pressure lowering medications in addition to healthy lifestyle changes. So now let's discuss drug management options and recommendations. First, it's important to recognize that for medical management, studies indicate that only about 20% of patients with hypertension followed their treatment plan well enough to improve, and up to 25% of patients fail to even fill their initial prescription. So apparently adherence isn't just an issue with lifestyle modification. A few highlights regarding drug management. The 5 major types are diuretics, angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, calcium channel blockers, and beta blockers. Beta blockers were less effective than calcium channel blockers and thiazide diuretics in preventing stroke in the general population. ACE inhibitors were notably less effective in preventing heart failure and stroke compared to calcium channel blockers in Black patients. Angiotensin receptor blockers may be better tolerated than ACE inhibitors in Black patients with less cough and angioedema, but they offer no proven advantage over ACE inhibitors in preventing stroke or cardiovascular disease in this population, making thiazide diuretics or calcium channel blockers the best initial choice for a single drug therapy. In fact, no class of medications was significantly better than thiazides and thiazide-like diuretics as a first-line therapy for any outcome. Given non-drug management is recommended not only as a preventive, but also initial management for the category of elevated blood pressure and also for those stage 1 hypertensive patients that don't have clinical cardiovascular disease. Let's look at some of these recommendations. Here we see a recommendation for losing weight if necessary, reduction of sodium, and increase of potassium. We also see what is called the DASH diet, or dietary approaches to stop hypertension. This is in fact a low sodium, high potassium, and low fat diet approach that will likely result in weight loss, in particular if coupled with the other recommendation of exercise. The DASH diet alone can reduce systolic blood pressure as much as 11 millimeters of pressure. With exercise, there are more specifics than in previous guidelines. For aerobic exercise, it must be performed 90 to 150 minutes per week at 65 to 75% heart rate reserve. For dynamic resistance, again, a recommendation of 90 to 150 minutes at 50 to 80% heart rate reserve, 1 rep max, and 6 exercises performed at 3 sets per exercise, 10 reps per set. For isometric, 4 2-minute hand grips with 1 minute rest at 30 to 40% maximum voluntary contraction, 3 sessions per week for 8 to 10 weeks. So what about manipulation? Well, as reviewed in a previous video, there are now 7 studies. Only 1 study using an upper cervical technique called NUCA demonstrated a significant effect. All other studies either had results that were not significant or the follow-up measurement was taken immediately after only one treatment. So let's summarize. Clearly, there is a strong national push for keeping blood pressure under tighter control due to its effect on mortality and morbidity. Chiropractors can play a crucial role in detecting hypertension, and for most patients with hypertension, participate in initial management. This includes elevated blood pressure and stage 1 hypertensive patients without clinical cardiovascular disease or an ASCVD risk below 10%. Again, lifestyle modification is recommended for a period of 3 months and then a recheck. To be clear, these new guidelines are not without controversy. In fact, after this publication, a systematic review was published concluding that the benefits of a lower blood pressure was found only for those with an initial baseline blood pressure of 140, contradicting the new guidelines and agreeing with the old guidelines. As usual, time will tell whether these newer approaches to detection and management are effective, or for the more cynical practitioner, whether these new guidelines are yet another attempt at increasing the profit of drug companies.